Okay, welcome everybody to this quarter's meningioma patient support group. As those of you that have come to these on a regular basis know, kind of that our standard format is to have a little bit of a educational presentation, followed by questions, followed by just general patient discussion. So I'm going to give a brief presentation. I'm happy to answer questions. There is a mechanism for you to submit questions. V, how do you want them to do that? Do you want them to?
Actually, the way we have this set up is not a webinar, it's a meeting. So we'll just wait to the end of the presentation.
Okay.
Then if anyone has questions, they can raise their hand. There's a feature on the little box to raise your hand, and then we'll just kind of have, open up to everybody.
Okay. And then after the question and answer, then I'll drop off and V will lead a patient discussion. So what I wanted to talk about today is kind of a broad anatomical classification for meningiomas, because when we talk about meningiomas, we often just lump them all together and say you have a meningioma, but they're not really they're not, you can't really think of them all as in one cookie cutter way. You have to think of them differently based upon location. And what I was going to do is classify for you the meningiomas based on about 8 general types, and show you the location of these types of meningiomas and the type of symptoms that can present based upon each of these locations, and also kind of strategies to manage them, because the strategies are different from location to location. So again, location determines a large part of what options are available, and also success of treatment. And this classification system that I'm going to present today is a classification system that generally neurosurgeons use when discussing these type of tumors. So I'm going to jump straight in. So before we talk about the 8 types, I just want to talk about one slide of where meningiomas develop. So this is a cross section here of a skull, followed by the meninges, followed by the brain. So here's the bone on the top. There's a fibrous layer called the dura, which is this blue layer here, and the brain is down here. And you can see between the blue dura and the brain, there's a layer called this arachnoid and pia. So here's the arachnoid. So meningiomas are thought to originate from the arachnoid cap cells. So the cap cell, these are cells right inside the dura here. And so anywhere in the brain where you have dura and arachnoid is where you could have the development of meningiomas. So on this schematic here, this is a picture of the skull kind of with the top removed, kind of looking down. So you're looking from the vertex of someone's head, and you can see that there's meningiomas can occur anywhere along the bone, the inner lining here. And you can see in this illustration here, you see a variety of names based on these meningioma locations. Generally, meningiomas are named by the bone structure for which they grow off of. So one of the meningiomas we'll talk about today is called a sphenoid wing meningioma. This is the sphenoid bone here. It's this curve here. It kind of looks like a bird's wing, so that's why it's called a wing, and it's a sphenoid bone, so hence the name sphenoid wing. And any meningioma that grows in this location is called a sphenoid wing meningioma. Well, on this cross section here, this is a vertical slice. You see that this meningioma here is called a convexity meningioma because it grows along the convexity of the bone. So again, nothing complicated here. We just name meningiomas based upon location by which they arise from. So the first category of meningiomas are what we just talked about in the previous slide. This is a convexity meningioma. So it grows off the curve of the bone along the outer aspect. So the nice thing about convexity meningiomas is that they are they are easily accessible. So this is the same tumor that I showed. This is a patient of mine who presented with this large mass, and they presented just with a seizure. So here's that curve of the bone here, right here. This is the skull. So it's a convex shape. So this is a convexity meningioma because it grows along the bone here. Now, the reason why I say these are relatively easy tumors is that the blood supply, the nutrition to the tumors comes along the dura, the bone lining right here. So when you treat a convexity meningioma, if you're going to remove it surgically, you actually get to the blood supply of the tumor first before you end up needing to address the tumor. And the nice thing about getting to the blood supply first is that you can cut off the blood supply to the tumor. And this allows you to devascularize or take away the blood supply of the tumor itself, which then makes the resection of the tumor easier because the tumor no longer bleeds because you've taken away the blood supply. So if you have a convexity meningioma, let's talk about symptoms, what symptoms you can get. This tumor pushes on the brain, so you can develop symptoms based upon the location of the brain by which the tumor pushes on. So if it's pushing on the area of the brain that controls movement, then you might get some weakness. If it pushes on the area of the brain that controls speech, then you might get some language dysfunction. Sometimes the tumor just pushes on the brain and you get some vague symptoms like headaches or sense of head pressure. And other times, in the case of this patient, they presented with a seizure. So if you have a large convexity meningioma, and this would be considered large, you can see this putting pressure on the brain. The optimal treatment is surgical resection. It's too large for radiation. But as I said, these are very easy cases to do because you get to the blood supply of the tumor first before needing to take out the tumor. So convexity meningiomas are the easiest type of tumor, meningioma tumor to address. Now, this is a large convexity meningioma. As I mentioned, surgery is kind of the mainstay. But if you had a smaller convexity meningioma, you could consider doing just radiation. So a small meningioma would be maybe 1/4 the size here, that's not causing pressure on the brain or not causing any symptoms. So again, large ones, surgery; smaller ones, you have the option of surgery or radiation. And if they're very small, particularly if they're an incidental finding, you have the option of observation. Now, one issue with observation, I think sometimes patients fall into the trap of thinking that observation is relatively risk-free. It's not if the tumor grows. So when you observe a tumor, we know they're tumors, we know they grow over time. So when you observe a tumor, you will likely, particularly if you look over a long enough period of time, have to deal with a larger tumor, and particularly the consequences of that larger tumor. So this is the same patient that I just showed you in the previous slide. We took out their convexity meningioma. You can see the brain has moved back into place. It's taken up all the space that the tumor initially occupied because the brain started there. It was just pushed away by the tumor from the skull. And once you take out the tumor, the brain pops back into place. So the second type of tumor I want to talk about is called a cavernous sinus tumor. So again, this is a schematic of the skull here. These circles represent where the eyes would be on the face over here. So the cavernous sinus is, you see it labeled right here. It points to this kind of complex web of structures here. Now, in this particular cartoon, blue are veins. And so you see the cavernous sinus points to a region where there's a lot of veins. You can also see it's also pointing to an area close to the center of the skull. So we're not on the edge anymore. We're kind of smack in the middle of the center of the skull. And so that's an important concept with the cavernous sinus location. When we look at a close-up of those blue veins, and here again, you can see these blue veins, this mesh here, we see it's not just a series of veins. There are a number of structures in this web of veins. And you see a number of these yellowish oval circles here and this circle here. These are all nerves. that are running through the walls of the veins. In addition, we see this structure here. This is the carotid artery, the artery that comes up from the neck that supplies the blood to the brain. So when you look at the outside, you might just see some veins, but when you do a close-up and look at the inside, you see there are a number of critical structures involved in this area. So what do these nerves control? These nerves control eye movement and feeling in the face. And so your ability to move eyes left, right, up, down, these are all controlled by these nerves. And of course, the carotid artery supplies blood to the brain, and without the blood flow, your brain would not survive. So the challenge of a meningioma in the cavernous sinus is the nerves and the carotid artery can be surrounded by the tumor, and then they can be entwined by the tumor. And so unlike a convexity meningioma, where you go in and you surgically remove the tumor, particularly if it's large, and it's very easy to do, a cavernous sinus meningioma is difficult, if not impossible, to remove completely with surgery, because there's too many small little nerves that can be stuck to the tumor. And sometimes the tumor, you really can't separate the tumor from the nerves. So if you operate in the cavernous sinus, there is a fairly high chance of causing some morbidity, some injury to these nerves. And there's a almost 100% chance of not being able to get all the tumor out. So a cavernous sinus meningioma, this is what one looks like on the MRI scan. This little black dot is the carotid artery that I showed you on the previous cartoon. So for something like this, when you see a cavernous sinus meningioma, particularly one of this size or smaller, we typically don't even recommend surgery. We recommend going straight to radiation, again, because of the location of the nerves. Now, you cannot see the nerves on the MRI scan, but they're running in this white tumor here. So if you try to do surgery, you may not be able to identify the nerves before they're injured. So for cavernous sinus meningioma, radiation is pretty much the standard treatment. The tumors in this location can cause a variety of symptoms. Again, the main ones would be difficulty with eye movement, some numbness in the face, occasionally headaches, but typically not things like weakness in the arms or legs or speech or language, because the location of the tumor is such that it wouldn't affect those functions. Sometimes you can have a tumor that starts in the cavernous sinus and grows quite large and sticks out into the brain. And in those situations, we may propose a hybrid treatment where you perform surgery first and debulk the tumor, but then you leave the portion in the cavernous sinus and then come back with radiation a few months later and treat that portion. So, radiation, as I said, is the mainstay for the cavernous sinus. This is the latest generation CyberKnife machine that we use to radiate cavernous sinus meningiomas. So the next type of tumor I want to talk about is called the olfactory groove meningioma. And these, again, this is, I'm going to show a lot of different slides about anatomic location, but because I just want to basically explain where these tumors start. So the olfactory groove is this location right here. It's called the olfactory groove because the smell nerves run along the skull here, and they exit through small little holes in the skull here to go out to your nose. So olfaction is the smell, and an olfactory groove meningioma is a meningioma that grows along this midline structure of the skull here and can impact some of the olfactory nerves. So this is a picture of a large olfactory groove meningioma. You can see this is a horizontal view here. You can see its location. This is the forehead, so it's right behind the forehead. This is a profile view. So here's the nose. Here's the tongue here. Here's the forehead. And we can see this fairly large tumor here. Now, this tumor is adjacent to the frontal lobes of the brain, and the frontal lobes don't have a lot of critical functions. So these tumors can become quite large over time before they're detected, because the brain that's being pushed on by the tumor, the frontal lobe, doesn't have a lot of function. Now, in the case of this particular tumor, you can see by the time it got this large, it's causing some pressure in the brain that causes some swelling in the brain. That's a signal, this white signal we see on this particular MRI sequence. It's called a T2 sequence, and it shows the pressure of the tumor pushing on the brain, resulting in swelling of the brain. So what kind of symptoms can you have with olfactory groove meningiomas? If they're very small, you may not have any symptoms at all. They're often incidental findings because they're not big enough to put any pressure on the brain in this location, and the brain doesn't have a lot of critical functions in this location. Now, if they get larger like this, patients can have some cognitive issues, they can have some headaches, they can have some seizures. And so if they're discovered at this size, they're often symptomatic. Now, how do you manage these? If they're this big, you have to pretty much start with surgery. That's the only way to get pressure off the brain. And looking at this image in the middle, you can see that the tumor is right behind the forehead. So the surgical approach for these is to kind of come in right behind the hairline down to the tumor and remove the tumor that way. This is a much smaller olfactory groove meningioma. So this is a profile view here. Here's the forehead, here's the nose, this is the tongue here. And you can see this round oval here. It's a little bit bigger than an almond. You don't see the pressure on the brain. This is the same view looking at it from a vertical slice. So here's the two eye sockets right here. You can see this one is small, and at this size, you could just treat this with radiation, or if the patient is older, you could consider observation, as long as the patient understood that, you know, there's a chance the tumor could grow. This is a recent patient of mine who presented with he presented with a 6-month history of some cognitive decline, and that was because he had this large tumor pushing on the brain and located in the olfactory groove. Couple things to note on this scan. The first is you can clearly see the large white mass that's the tumor, but you'll see a number of these smaller white squiggly lines here. These squiggly lines are blood vessels. So when you approach an olfactory groove meningioma, unlike the convexity meningioma where you get to the blood supply first, with the olfactory groove meningiomas, you get to the blood supply last. So the blood supply to these tumors comes along the base of the skull here. So if you were to approach surgically this way, coming down from the top here, you're going to get to the tumor before you can eliminate the blood supply, and that can create a lot of bleeding during the tumor resection. For some of these larger tumors, we will consider a procedure called embolization. Embolization is a process in which the radiologist will inject glue into the tumor a few hours before the surgery to try to eliminate the blood supply by gluing the blood vessels that are going to the tumor. And this can often make surgery easier to do. So again, large tumor, blood vessels adjacent to the tumor. When you do this resection, the blood vessels are critical to avoid injury to it. So this is the scan after the surgery. You can see the meningioma, which was large on the previous slide, is now gone. There's a small little remnant of tumor here. This tumor was stuck to two of the largest blood vessels in the frontal lobe. They're called anterior cerebral arteries, and they supply the area of the brain that controls the legs in part. And so we spent a fair amount of time trying to remove this last section of the tumor from the blood vessels. And it was clear that it could not be safely done without potentially injuring the blood vessels. So we decided to just leave that remnant behind, figuring that if it did grow, we could do radiation. This patient so far has had several MRI scans after the surgery, and this little remnant hasn't grown. So we've not had to do any treatment other than observation at this point. Okay, so the next tumor I want to talk about is the Sphenoid Wing meningiomas. And again, looking back at the anatomy of the skull here, this is a sphenoid bone right here, and it kind of arcs out like the wings of a bird. You can see one on each side. So this is called the Sphenoid Wing. We generally classify tumors of the sphenoid wing into two types. There's what's called a lateral sphenoid wing, the tumor out here, and what's called a medial sphenoid wing, which is a tumor right here. So Again, this cartoon, here's the sphenoid wing. It's this curve coming out here. So this is an example of a tumor of the sphenoid wing and what it looks like. On the horizontal MRI scans, it looks like the sphenoid wing is right behind the eye. So the tumor looks like it sits right behind the eye. What symptoms can you get from a tumor in this location? Generally, the tumors in this location cause headaches or seizures when they're small to medium size. This would be a medium size sphenoid wing meningioma. You can see a little bit of swelling in the brain behind the tumor. This is that darker gray material in the brain right behind the tumor. And so that shows that this tumor is causing pressure on the brain. So when they're this size, again, headaches and seizures. If they get much larger, you can start to develop other symptoms such as eye symptoms, or even cognitive decline, or potentially speech difficulty. Most patients that are right-handed, which are the majority of the population, have language located on the left side in the inferior frontal region. So if a sphenoid wing meningioma that's located on the left side, like this tumor is, if it gets too large, it may compress the language area of the brain, and then that can cause speech dysfunction. So how do you manage the sphenoid wing meningiomas? For the most part, they can be resected at least either completely or near completely. The challenge on the larger meningiomas of the sphenoid wing is the proximity to the blood vessels. So you got to be very careful that you don't injure what these two blood vessels here, this structure and these blood vessels here, they're called the middle cerebral artery. They typically supply blood to the area of the brain that controls hand movement and arm movement. So if those are injured, the patient could lose function in the hand. If the sphenoid wing meningiomas are small, you can treat them with radiation. Here's the same tumor, looking at it from profile view. Again, for most patients looking at the films, it looks like it's kind of right behind the eye. So this is another view. This is a vertical view of one of my patients who presented with a sphenoid wing meningioma. And this patient presented with headaches. But you can see the pressure on the brain. This black structure is the fluid-filled space of the brain. This is the normal structure shape. And you can see on this side, it's compressed, it's smaller because the tumor is pushing on the brain and compressing it. So this is why the patient had headaches. He's got a mass the size of a tennis ball inside his brain, pushing on the brain. The brain could tolerate it for a certain period of time, but at this point, the brain just lost its ability to move any further out of the way, and the patient started developing symptoms. So how do you manage this? Again, at this size, surgery is the way to go, and so that's what we did with that patient. This is a smaller sphenoid wing meningioma. Again, you can see the sphenoid wing right here. This tumor is small enough to potentially treat with radiation. I did want to point out that tumors they grow from the inner lining of the skull. Sometimes they can actually grow into the skull or thicken the skull. And if you look carefully, you see this triangle here of bone right next to the meningioma looks a little bit different than this triangle here on this side. So this could either be hyperostosis, which is a reaction in normal bone to the meningioma, or it could potentially be tumor infiltrating into the bone. The next type of tumor I want to talk about is called a Sella Meningioma. So the Sella, short for Sella turcica, is this region right here. It's kind of almost the exact spot center of the base of the skull. And in the Sella is where the pituitary gland lives and is occupied the space there. The pituitary gland makes a variety of hormones such as growth hormones, FSH and LH, the hormones of female menstrual cycles. They make cortisol, they make thyroid stimulating hormone. So there's a lot of critical endocrinologic or hormone function in the Sella region. You can also see it's not a very big space. It's kind of a little small pocket there. And so when meningiomas occur in this location, they can create some problems related to the hormone dysfunction. So this cartoon here shows the Sella right here. It's kind of a magnified view. It's a cup. See, there's a bone all the way around it with the pituitary gland living in the cup. Now, in this location, and this cartoon shows the nose here and the nasal passage is here. So air comes in, this is how you breathe, and it comes down your throat here. But you can see this is all air all the way down to here. So when you have a tumor meningioma in the Sella location, it is potentially one of the few types of meningiomas that you can treat with an endoscope. You can stick a camera down here, drill off a little bit of bone if necessary, and access the tumor without opening the skull. So here's an example of a Sella Meningioma here. It's a meningioma sitting right above the pituitary gland. And again, this is the nose here. And from here all the way to the edge of this white tumor here is all air. So you can take a camera, come all the way down here. There's usually a little eggshell of bone you can remove there, and then you can be removing the tumor with an endoscope, and that's all done just down the nose. So something like this is a little cartoon that shows how we can stick the camera in the nose and get up to the head there. So usually Sella meningiomas are picked up potentially smaller in size than other meningiomas because they're located in the center of the skull, a little bit more critical structures there, more likely to put pressure on something important earlier and lead to diagnosis. Some Sella meningiomas can be treated with radiation. They're usually ones that are not compressing or displacing the optic nerve, which is the vision nerve. So if we go back and look at this side, the vision nerve would usually sit right above the meningioma there. So if the tumor is small and the patient doesn't have any vision problems, you can consider a radiation for these. But generally, a lot of times these are removed surgically, with the midline endoscopic approach being a common approach for that. The sixth type of tumor is called the Tentorial Meningioma. So this is, again, a picture of the skull. The forehead's here. Here's the upper teeth. The tentorium is a fibrous web along the back here. It's what separates the cerebrum, the higher cortex that we, thought and movement and language are located from, the cerebellum, which is the motor, the coordination area of the brain down here. So the tentorium is a fibrous web, and any meningioma that grows off of the tentorium is considered a tentorial meningioma. So this is an MRI scan showing a tentorial meningioma. So this curve here is the tentorium. So here's the curve on the left side, and then here's the curve on the right side here. And this is a tentorial meningioma because it started at the tentorium here and is growing outward into the brain. So this is a vertical slice. This is the profile view. And then this is the horizontal view here. So what symptoms do tentorial meningiomas present with? Generally, they're deeper, so they don't cause language dysfunction. They can cause headaches and seizures. They can affect the optic, the visual cortex, the optic pathways that come to the back of the head here, visual cortex. So you could have some visual deficit, not having good peripheral vision, for example. The treatment for tentorial meningiomas depends largely upon the size of the tumor. This tumor here, it looks like it's causing a little bit of edema or swelling in the brain, it's pushing on the brain. And so this tumor is getting to the point where we would start to lean towards surgical resection versus radiation. But smaller tentorial meningiomas can be treated with radiation. If the tumor is a fairly large tentorial meningioma, and it's wrapped around some of the more important blood vessels that down toward the center of the brain, you may approach this from a hybrid therapy where you do a partial surgical resection, we call a surgical debulking, followed by radiation to a remnant of the tumor. And that's I think a strategy that is probably not used as often as it should be. It's I think less risky for the patients to do kind of a hybrid therapy in many cases than to try to do all surgery or potentially all radiation. Okay, just two more. The next is called a Petrous Meningioma. So this is the Petrous bone here. It's this bone toward the back here. This was the Sphenoid Wing here. Here is the Sella, and then this is the Petrous bone here. So a tumor that grows along the Petrous bone toward the back of the head is called a Petrous meningioma. And this is kind of what one looks like. So here's the Petrous bone here is this black structure. Here's the Petrous bone on the right side. And you can see the Petrous meningiomas growing off of there. it pushes on the cerebellum. So here's the cerebellum here. This was the tentorium, the band that separated the higher cortex up here from the cerebellum. So this tumor is pushing on the cerebellum. So what symptoms would you get from a Petrous meningioma? If it pushes on the cerebellum like this, you can get balance and coordination issues. You're not likely to get seizures. Seizures occur in the higher cortex here. Seizures usually don't occur in the cerebellum. So this typically would not cause seizures. It could cause headaches. Anything that causes pressure in the brain can cause headaches. If the Petrous meningioma gets down closer to the midline, it could start to disrupt some of the what we call cranial nerves. And these are nerves that control feeling in the face, movement of the face, hearing, swallowing function. So if the Petrous meningioma gets involved in those areas, you can sometimes develop symptoms related to those nerves. Sometimes the Petrous meningioma can push on the trigeminal nerve, which is the nerve that controls feeling in the face, and that can cause very severe, sharp electrical shocks of facial pain. So how do you manage the Petrous meningiomas? If they're very small, you can observe them. If they're small to medium and not causing a lot of problems, radiation's a good option. If they're larger, we consider surgery. Surgery in this back area here is a little bit more challenging than surgery up here in the top, partly because when you operate here in what we call the supratentorial, above the tentorial region, you have a lot more space. When you operate in the infratentorial region, the region below the tentorium here, it's a much smaller region, and so there's less maneuverability. There's less variety in different surgical approaches that you can use. You just have a smaller workspace, so that's partly why it's challenging for some of these in this location. The last type of tumor I want to talk about before we go to questions is called a Foramen Magnum meningioma. So going back at our standard image of the skull, we talked about the different skull anatomy. This is the Foramen Magnum right here. It's the hole at the bottom of the skull toward the back of the head. And this is the hole that the spinal cord extends through. So you might say, well, this is how the spine and all the nerve roots that come out of the spine get out from the brain. So the Foramen Magnum is a pretty tight opening. It's a little bit thicker than your thumb, but not much more so. And the spinal cord is going out of that hole. So in terms of what a Foramen Magnum meningioma looks like, this is a couple of different views from the Neurosurgical Operative Atlas. This is a profile view here, and here's a large Foramen Magnum meningioma pushing on the spinal cord. You see the spinal cord is displaced, it's bent over the edge of the Foramen Magnum meningioma. This is a horizontal slice here. The meningioma is this white circle, white oval here, with the spinal cord being this gray crescent here. So what symptoms can the Foramen Magnum meningioma cause? As expected, by pushing on the spinal cord, it could affect anything from the neck down. So you could develop weakness or numbness in the arms or legs. You could have bowel or bladder dysfunction. You can have even some swallowing function if it impacts some of the lower nerves that are involved with swallowing function. With Foramen Magnum meningiomas, if they're identified before they're causing a lot of symptoms, you can consider radiation. If you wait and the meningioma gets larger and or you get more symptomatic, then you're pretty much looking at likely to have surgery to get the pressure off the spinal cord. With these, and again, like many of the complex skull-based locations that I've shown, for Foramen Magnum meningiomas, oftentimes it can be challenging for surgeons to get every last bit of the tumor out. And so a hybrid therapy where you go in and do a surgical debulking or partial resection to get out the majority of the tumor and get pressure off the spinal cord and brain, followed by focused radiation, sometimes allows patients to get through the treatment and procedures with less risk than to try to do it exclusively with surgery. So I'm going to stop there and answer any specific questions that have come up for the cases so far. So I don't know if, I don't see anything chat thing, so you might have.
Yeah, so let me go ahead and see if I can go ahead and unmute everyone. I guess if you have questions, you can unmute yourself or raise your hand. Let me.
Hi, I was wondering, is there any one of those different types that have more regrowth chance than others?
That's a good question. So tumors that you can get that you can remove completely, like those convexity meningiomas that I